discuss about urinary tract infections. At the learning objectives are different classification, pathogenesis, and the clinical course of this topic. So, basically, urinary tract infections are very common throughout life, both in healthy as well as in immunocompromised or debilitated persons. It is most commonly found in females with a lifetime occurrence rate very close to 50%. Urinary tract infection is most commonly caused by uropathogens, that pathogens arise from the fecal flora and predominantly E. coli that ascends the urethra to infect the bladder. Normal defense mechanism against urinary tract infections includes complete voiding, which removes bacteria from the bladder, urinary acidification from concentrated urea and other excreted organic acids, vesico-urethral valves, which prevents backward flow of the bacteria to the upper urinary tracts, phagocytosis, secretory immunoglobulins like IgA productions. So all these are the defense mechanism. So when there is incomplete defense mechanism, or whenever there is hindrance in the defense mechanism, so what happens? A person develops urinary tract infection. Before going into the detail, I would like to have a look on the anatomical uh, um structures of the urinary tract system. We have divided the urinary tract into upper UTI and the lower UT. Upper UT includes kidneys, adrenal glands, and upper half of the ureters, while the lower urinary tract involves bladder, urethra. It also includes male prostate in case of males and the lower part of the ureters. So when we talk about the upper UTI and the lower UTI, so you should have a complete picture of that particular part. So what are the risk factors? Basically, why we say that it is very common. The risk factors includes genetic causes, behavior causes, iatrogenic, anatomical, and physiological. Genetic causes includes all the family hereditary, like a person is having history of urinary tract infections, so that person would be more prone to develop. Susceptible uroepithelial cells. In case of females, sometimes vaginal mucus properties like the vaginal epithelium does not produce enough mucus. So what happens? It dries out, and the bacteria who is capable of doing vaginal infection also gets entry, and that's the way it produces uh, mm, infections. Vaginal mucus actually allows E. coli binding more rapidly. So that's why. And the susceptible uroepithelial cells, they secrete less IgA. As I have told you that secretions of IgA is a secretory immunoglobulin. So it is also one of the defense mechanism. So what happens when the uroepithelium lacks in secretion of IgA, which is a main humoral defense mechanism at the physiological mucosa. In case of behavior changes, sometimes what happens that increased post-voidal urine volume, which allows more time for bacterial growth, and frequent or recent sexual intercourse also introduces bacteria if there is hygiene is not properly adopted. So what happens that it causes UTI. When we talk about iatrogenic and drugs, so inducing catheters, excessive use of antibiotics, and excessive use of spermicides. What happens that a person who is having inducing catheter due to some reason, it it basically catheterized patients have got an ascending route for perianal bacteria to enter the bladder. And similarly, the excessive use of antibiotics disrupt the normal flora of the uh, area like bladder or vagina. So it causes high chances of developing UTI. Spermicides causes spermicides causes irritation and attachment sites for E. coli. As far as anatomical and physiological cause risk factors are involved, there is a vesico-ureteral reflux, which we have studied detailed in my last class. So what happens that vesico-ureteral reflux causes urinary retention and allows more time for the bacterial growth. The retrograde flow also allows bacteria to ascend to the kidney. Females usually have short urethra, so they have more chances to attain this infection. Pregnancy results in progesterone-mediated smooth muscle relaxation to the bladder and ureters and compression of the ureter by the uterus. So both results in urinary retention for increased bacterial growth. So these are the broad spectrum risk factors which are associated with the formation of this urinary tract infections. As far as classification is involved, we have divided into different classification, that is asymptomatic bacteriuria, symptomatic bacteriuria, uncomplicated, and complicated. In case of asymptomatic bacteria, what happens that it is normally found in among adults and in which their symptoms are not present, but bacterial count, significant bacterial count is present. Usually bacterial count we have when we go for the diagnostic of this urinary tract infection, and when we culture the urine, so we have decided, or we have determined a specific amount of colony forming units of bacteria that are responsible for causing significant UTI. So in case of asymptomatic bacteriuria, what happens that bacterial count is enough to cause UTI, but the symptoms are not present, and these are usually found in adult patient. In case of symptomatic abacteriuria means that the patient is having uh, symptoms, but the urine is devoid of any bacteria. Although the bacterial count is bacterias are inside the body, like bacterias are causing infection, but they are not excreted in urine. So there are different causes like that urinary tract infection is not due to bacterial cause. It could be some other cause like some protozoas. They are also causing some mycobacterial cause. So the cause of this UTI could be other than bacteria. That's why the symptoms are there, but the bacteria are not isolated in the urine. In case of uncomplicated bacteriuria, it is one of the most important infections in primary care. It is usually found in the children and infants, and the most bacterial infection in children less than 2 years of age. During the first 6 months of life, it is more common in boys. The outcome is usually benign, but it can progress to renal scarring in early infancy, especially when it is associated with any congenital anomalies of urinary tract. Renal scarring, as we have already studied, that it leads to complication in adulthood, including hypertension, proteinuria, chronic renal failure, which requires dialysis. So in case of complicated bacteriuria basically occurs when there is some structural functional abnormality of the urinary tracts, or the person is having other comorbids along with, like if there is, in case of congenital anomaly, if the urinary tract is not completely formed, so the the UTI could be due to the complicated bacteriuria, or if the person have other comorbids like diabetes, hypertension, or any other autoimmune disease, any other immunocompromised situation. So the UTI could be due to complicated bacteriuria. Recurrent UTIs is divided into relapses and reinfection. In case of relapse, what happens that the repeated infection with the same organism. Relapse means that the same organism, once it is treated and eradicated, but again it gets entered and causes infection. So it indicates a persistent infectious condition, and it is sort of a persistent infectious cause. In case of reinfection, they are basically due to the same organism, or reinfection means that the infection is continuously occurring. So it can be resolved after appropriate treatments, and they are more commonly in young healthy female, even those women that having anatomically and physiologically normal UTI. So this is very important. And in significant bacteriuria, what happens that the bacterial count is more than 10 is to power 5 bacteria per ml CFU. Um, we have counted the bacteria in the form of CFU, that is colony forming unit, of a urine in a clean catch specimen. That means the specimen is collected according to the recommendation, but the count of bacteria is more than 10 to power 5 CFU per ml. Usually one third of symptomatic females have CFU less than that, like the females, one third females having symptoms, but the count is not that much. So the bacterial count of 10 is to power 2 CFU per ml has a high positive predictive value of cystitis in symptomatic females. Etiology. Etiology is very interesting, and it is very important that bacteria basically is the most important cause. As we have already discussed in my previous lectures, that the bacterial cause or the obstructive cause are one of the most important predisposing factors that usually allows the formation of infection. So the predominant bacteria are the E. coli, then Klebsiella, then Proteus, but 75 to 95% of the cases, E. coli is the predominant bacteria. When we talk about the gram-positive bacteria, they are less common, and Staphylococcus saprophyticus, that causes urinary tract infection in young females. So whenever we isolated Staphylococcus saprophyticus in young females, so it is one of the most important finding. Similarly, group D bacteria, Enterococcus faecalis, group B streptococcus, group P streptococcus um, A. galacti, that causes urinary tract infection in pregnant females, and if it is not treated, so it will cause abortions, or it will cause neonatal meningitis. So it is very important to find out the cause of the disease or the infection and treat it immediately. In hospitalized patients, again, E. coli is one of the most important bacteria, and similarly other bacteria, as I have mentioned, that Klebsiella, Proteus, Pseudomonas, Staph sapro. So these are basically the pathognomic of this urinary tract. So you should know the etiology, because when we know about the bacteria which is causing infection, so we can go for better treatment options. Predisposing factors. Number one predisposing factor is the abnormalities in the urinary tract that interfere with natural defenses. Abnormalities are acquired or congenital. So what happens whenever there is a obstruction, as we have studied, that uh, inhibit the flow of urine, and it usually disturbs the normal physiological mechanism of passing of urine outside the human body. So what happens whenever there is an obstruction, there is an accumulation of the residual urine, and in this residual urine, what happens? There is accumulation and multiplication of bacteria that eventually cause infections. So conditions that results in radiolemes in case of prostatic hypertrophy, in case of ureteric structures, in case of tumors, in case of stones. Tumors could be from outside of the urinary tract, like in case of mats, what happens that they pressurize the urinary tract from the outside and they cause obstruction, which further results in accumulation of residual urine. Anticholinergic drugs and sometimes neurologic malfunctions like diabetes, like in some spinal cord injuries, in case of a stroke. So what happens, all these situations are leading to the formation of urinary tract infections. Other risk factors, like if a person is catheterized or if some surgery has been undergoing, like mechanical instrumentation, in case of pregnancy. So these are other factors that are associated with the predisposing. So this picture is very important because through this picture we can have a look of pathogenesis, that what is going on and how the urinary tract, basically how the urinary tract infection occurs and how the bacteria gets entry into the uh, upper urinary tract. So what happens that it starts with when the uropathogen that resides in the gut contaminate the periurethral area. This is the step number one. What happens that the urinary tract system and our um, gastrointestinal systems, the openings are very close. So what happens that due to unhygienic conditions, due to the contamination of that periurethral area, so uropathogens are obviously one of the most important pathogen is E. coli. They get enter into the urethra. You see that the bacteria are gaining entering into the urethra. So this is the step one, that how they get enters into the urethra. So what happens if the person is immunocompetent? So this bacteria could be stopped over here, or it will not cause any infection. But in case of immunocompromised patient, in case of extreme age groups, these bacteria enters into the bladder, and what happens that they basically colonize, they get colonized into the urethra, and then their further migration into the bladder, then enters into the bladder, and they express pili and adhesion. Like these bacteria, they have some specific adhesion molecules and structures that they manifest when they enters into the bladder. And what happens through that adhesion factors, or through that pili, they get invasion of the epithelial lining of the bladder. Once they get invaded, what happens are host inflammatory response, including initial, we already know that our first acute inflammatory cells are neutrophils. So what happens that the neutrophils infiltration starts, as we have seen there. These are the neutrophils. When these bacteria get enters into the bladder, they start manifesting their adhesion molecules and the pili, through which they get invasion into the bladder epithelial lining, When they get entered into the bladder epithelium, our host inflammatory cells become active and they start manifesting themselves. So what happens that some bacteria, um, they uh, evade the immune system either through host cell invasion or through morphological changes that results in resistance to neutrophils, while the other bacteria undergo multiplication and forming biofilm formation. Biofilm formation is a very important structures that are formed by the bacteria. Biofilm formation, basically biofilms are resistant uh, uh, accumulation of the bacteria, and when the biofilms are formed, usually they resist to inflammatory host cells, or sometimes they are highly resistant against antibiotics. So these bacteria, once they form biofilms, they start producing toxins and different enzymes like proteases that further damages the host cells. And they also, despite of damages the host cell, they also produces some essential nutrients that promote bacterial survival, and these essential nutrients helps them to reach to upper part of the kidney. So what happens that kidney colonizations results in bacterial toxin production and host tissue damage. If left untreated, UTIs can ultimately progress to bacteremia if the bacteremia if the pathogen crosses the tubular epithelial barrier in the kidney. So what happens that initially the uropathogens get entries into the bladder through the urethra. Inside the bladder, they produces adhesion molecules and get invaded into the epithelial lining of the bladder. Once they start invading our host inflammatory cells, they come at the place of accident and they start removing these extracellular bacteria. But if the immune system is not as strong, as I have told you, in case of immunocompromised and old patients, so what happens that these bacteria further produces biofilms and they resist the inflammatory attack or the host defense mechanism of the human body, and then through this they get they produces further nutrients that helps to gain entry into the upper part of the urinary tract and help in multiplication of those bacteria. So in this way they reaches to the upper part. If they reaches to the tubular system of the uh, kidney, and they disrupt the tubular epithelial lining, and they destroy the tubular barriers that are present in the kidney, so it will further reach causes the bacteremia. So that uh, this is the way that how the urinary UTI develops. So in usually what happens, the most common cause of compromised bladder is catheterization. Whenever the person is catheterized, it gains a very open entry of the pathogens inside the urinary tract system. And usually colonization occurs, and through the catheterization, it leads to the damage. But if it is noticed in initial stages, so the situation could be reversed. Usually in case of catheterization, what happens, fibrogen accumulates on the catheter. So that provides the ideal attachment for the uropathogen that further express fibrinogen binding proteins. So infection induces neutrophil infiltration, but after their initial attachment to the fibrogen coated catheters, the bacteria multiply and they form biofilm. So this is basically the pathogenesis of how the bacteria gets enters into the urinary tract and how they causes infection. Again, this is a picture in which I a quick review, or you can quick recall, which I have told you, that urethra get colonized, and then the bacteria gets entry into the bladder. They disrupted the uroepithelium, and then after penetration, the uroepithelium, they start multiplying and form biofilms. And then once the bacterial colonization occurs and biofilm formation occurs, so the bacteria gets entry into the ureter, then through the ureter into the kidney. Bacterial toxins play a very important role in inhibiting the peristalsis. Peristalsis is very important because it allows the smooth flow of urine from the kidney through the ureter into the bladder and then expel out through the urethra. But these bacterial toxins, they inhibit the peristalsis. So what happens that they can easily access to the kidney. Once they get entry into the kidney, what they do, that they disrupt the renal parenchyma and cause inflammatory responses like pyelonephritis, which we have studied earlier. And finally, in case of acute pyelonephritis, as we have discussed, that glomerulus is spared, but there is suppurative inflammation inside the kidney, so it can be reversed. But once it leads to the chronic condition, so there is a scarring of the kidney, interstitial nephritis, and it causes atrophic conditions of the kidney. So you can imagine that the urinary tract infection is not a very easy, or it is not something which we can ignore easily. If this infection will not treat properly, it will cause uh, irreversible damage of the kidney, as in case of chronic pyelonephritis. Once the kidney gets atrophied, so it will not regenerate and get reversible normal function. So the main purpose of understanding this pathogenesis of UTI, that we should understand the importance of this infection, that how dangerous it could be if it is left untreated. Sign and symptoms, basically it is divided according to the site of infection. Like in case of urethra, burning with urination or simple discharge. But in case of bladder or cystitis, there would be a lower discomfort, abdominal discomfort, continuous painful urination. It could be a blood hematuria could be occur, or sometimes there is a pressure in the pelvis. When the kidneys are involved, so what happens that the symptoms of acute pyelonephritis would occur, as I have discussed in my last class, that there are triad of symptoms: uh, fever, pain, and nausea, vomiting. So, and then further, when it is progressive towards chronic conditions, so it will cause polyuria, dysuria, nocturia. So this sign and symptoms will be according to the site that is involved. Signs and symptoms, basically in case of elderly patients, the patient would present with the specific urinary symptoms, as we have discussed that it is associated with the site involved, or it could be shown with altered mental status. And sometimes a patient would complain of gastrointestinal problems, like they could be a diarrhea, nausea, vomiting, fever. So the elderly patients would present in a very different manner. In case of catheterized patients, sometimes there would be no symptoms. The patient would have no symptoms, and he will be caught uh, as infected by the urinary tract symptom infections by the investigations, because in case of catheterized patient there are certain investigations, the change of catheter after a certain period of time, and urine cultures are mandatory, so that the person initially would have no symptoms, but he will develop fever or the flank pain in later stages. Catheterized patients are usually old age patients, immunocompromised patients. So these patients uh, should be very carefully examined on regular basis, because symptoms are not specific in these cases. Then pyuria, hematuria, and proteinuria. Pyuria would be like if the WBC is greater than 10 WBCs per cubic mm. It signifies the presence of inflammation. That's called the pyuria, and the pyuria is very, very important in case of UTI. Sterile pyuria means that is associated with urinary tuberculosis, chlamydia, and fungal infection. As I have mentioned, in case of um, symptomatic abacteriuria, the causes could be other than bacteria. So that type of UTI presents with sterile pyuria. Hematuria basically is non-specific, and it may indicate other disorders, like if a person is having calculi or tumors, so he will also presents with hematuria. Proteinuria is usually associated with chronic kidney diseases, and it shows the presence of infection and other conditions, like if a person is hypertensive, so he can also presents with proteinuria. So there are specific investigations are mandatory that has to be done for the evaluation of the UTI in case if the person is presenting with proteinuria. So the lab diagnoses are very, very important, that what lab diagnosis and how they should carry it out. So first of all, urine collection, examination of urine, and the midstream clean catch urine. What is midstream clean catch urine? It is very important for females. As I have mentioned, that female has got short urethra, so they are more prone to develop infection. So in case of midstream clean catch urine, what happens that whenever a female is going to collect her urine, she should clean her uh, periurethral area with soap water, and then she has to discard first half of the urine, and then she collect, after discarding first half of the urine, she should collect mid half of the urine. That's called the midstream clean catch urine. But what happens that usually females, they don't know how to collect the urine, so whenever they send urine for examination in labs, and due to the miscalculation, the results are not accurate. So it is very necessary that a person who is going to collect his or her urine should know that how the urine should be collected. Suprapubic aspiration is basically the best method, but it is usually it has associated with certain conditions. It is not applicable for all type of collection of urine. Like a person is bedridden, or if suppose a person is, if the urine is not enough urine is not collecting, so in certain conditions what happened that suprapubic uh, aspiration is recommended. In case a syringe is inserted at the specific point just above the pubic bone after palpation, and it directly reaches to the bladder, and it will take out the urine from that part. Then collection of urine by use of a catheter. Sometimes what happens, there is single catheter, in and out catheter that is used, and sometimes a person has to be catheterized because the person is bedridden or the person is associated with some neurologic conditions. So it's the way to collect urine is by catheterization, and usually it is associated with old age patients. So what happens, as I have told you, that there is very less chances of having a midstream clear catch urine. Usually females don't know the criteria of collecting urine, so whenever they send urine for urine culture, it is mixed with the contamination. So the chances of negative results are much higher. So it's what we do, that we ask the patient to send her urine again after explaining her the correct methodology of correcting urine. So this is uh, it is very important that urine should be collected on time. Urine transportation, it should be processed within 22 hours of collection. If urine cannot be delivered to the labs within 2 hours, so the samples could be stored for 24 hours at 2 to 8 degrees centigrade. And usually urine collection should be done in a tubes with preservatives like boric acid glycerol or boric acid sodium. These preservatives, they inhibit the growth of normal flora or contaminated bacteria, and they allow the pathogens to grow in sufficient amount to be detected. So this is very important, that the collection of urine should be proper, the transportation and the storage would be proper. Otherwise, what happens that the fecal pathogens, they multiply in such a rapid rate, so that we cannot achieve our uh, true positive results. We usually have false positive results due to due to gap in the process of collection, transportation, and storage of urine. So what we do after getting after getting urine, we have a microscopic examination. In microscopic examination, we go for gram stain, and we go for urine DR. Urine DR is not the microscopic examination. Urine DR is complete process of uh, uh, complete process of how the urine is treated under different biochemical tests to get the clear result. So microscopic examination is performed with manual or automated light microscopy. The leukocytes, as I have told you, that pyuria defined as greater than 5 to 10 leukocytes. So if the bacteria would be greater than 15 bacteria under high power field in the urine, can be helpful in diagnosing UTI. Occasionally, we can have a hematuria in the presence of bacteriuria or pyuria, that also indicative of UTI. So sometimes the squamous cells, epithelial cells may usually shows contamination, and WBC cast, that usually shows upper tract inflammation or infection. Pyuria and bacteriuria can both be helpful in establishing presence of infection. So absence of pyuria with bacteriuria could suggest colonization or contamination rather than active infection. However, if bacteria constantly shows higher sensitivity and specificity than bacteriuria, and in the context of clinical symptoms and dipstick urine analysis, so it would be more accurate for UTI. So microscopic analysis, particularly bacteriuria, is helpful for ruling out and diagnosing UTI along with the patient's clinical presentation. So dipstick test is also very common, and it is used for the different purposes, not only for nitrate. So in this is a chemical analysis in which we look for the leukocytes, nitrate, urobilinogen, proteins, pH, blood, specific gravity, ketones, bilirubin, and glucose. So all these are very important in diagnosing different disease. Like for glucose, it is used for diabetes. Bilirubin is used for liver disease. Ketone is also used for liver disease as far as ketone acidosis, like in diabetes. Specific gravity is also associated with different hematuria, that is presence of blood. pH of the urine is also very indicative of, like, some bacteria, they grow in alkaline pH. Usually the pH is 6 pH is considered for the urine, but some bacteria are more prone to grow in very low pH, like 2 and 3 pH. So by examining and by evaluating all these parameters, we can have a we can move towards a specific diagnosis, and also we can see the presence of fungus in this chemical analysis. This is the dipstick, and what it is, a machine. This is the analyzer that used for the analysis of chemical analysis, and this is the whole procedure, that the urine of the patients should be placed in a test tubes, and these test tubes are put inside this analyzer, and this um, strip is dipped in each test tube. For each test tube, there is separate strip that has to be dipped. So after dipping for a particular period of time, these steps will be read or evaluated by using this control card, and then we when then we can evaluate the results. Nowadays all these processes are on machines, but in past few years this activity was manual. So manually they have to dip the strip inside the test tubes, and then they have to read along with the this card. So the color change would indicate the different results. So this is the way how dipsticks works. Urine culture is gold standard for the identification of infection, and it is considered the most appropriate screening test for asymptomatic bacteriuria in pregnancy, symptomatic bacteriuria, for reinfection, for relapses, for all the types of different UTI. So it is the thing is that the urine specimen are collected through clean catch of midstream urine, or through catheterized specimens, or through the suprapubic collection, and some other ways. So urine culture is basically a quantitative method. We have to quantify the bacteria, and in case of collection of non-invasive specimen, like the if the urine is collected by the patient, him or herself, or the urine is collected through uh, in and out catheter. So what happens? The amount that has to be taken is very important. It should be 1 microliter, and for that it allow the detection of 10 is to power 4 or 5 CFU per ml. If the urine is collected through non-invasive procedure, so 1 microliter would be enough to inoculate on the particular bacterial medium, and the quantity and the detection of the or the quantity of bacteria would be 10 is to power 4 or 10 is to power 5 CFU per ml would be enough for the identification of infection. But in case of invasive collected specimens like suprapubic aspiration, or for the culture of yeast, 10 microliter of urine should be cultured, and the CFU could be 10 is to power 2 CFU per ml. So first of all, you should know that the urine culture is gold standard. How much quantity is taken? for quantitative cultures, for invasive and non-invasive specimens. Quantitative urine cultures depends on the properly collected urine. Urine should be sterile and the number of bacteria. And as I have told you that in case of symptomatic abacteriuria, one third of the symptomatic women have bacterial count greater than 10 is to power 5. So these are the some basic uh, requirements you can say that is used for urine culture examination. Media used for urine culture are the clad. Actually, these are the different plates that are enriched for the growth of the bacteria. So when the urine having bacteria is put on these plate, or you can say that inoculated on these plate, and when bacteria gets their nourishment, so they will grow. And when they grow, we can identify that which bacteria is present and which is responsible for causing infection. So these are the different medium like clad, McConkey's, blood, chrome agar, and SDA. SDA is specific for yeast. Desired outcome. Desired outcome would be why we are doing all these investigation, because we want to treat or prevent systemic consequences of urine infection, as we have discussed that if the infection is not corrected initially, so it will cause worst outcome. Then eradicating the invading organism and reoccurrence or reinfection of the patient. Management includes initial evaluation. First, we have to initially evaluation, selection of antibacterial products, and selection of duration of therapy. Treatments are the main treatments for the antibiotics. That is the main treatment for all UTIs. Antibiotics are available, and it depends upon many factors like whether it is a complicated or uncomplicated, primary or recurrent. And treatment also decided on the basis of the male or the female, pregnant, non-pregnant, hospitalized, child. So in case of asymptomatic bacterial risk factors, as we have discussed, are usually the risk factors are universal. They are not associated with a specific type of bacteriuria, but they are usually um usually almost same for the other type of bacteria like asymptomatic bacteriuria. So for the asymptomatic bacteriuria, patients usually have no symptoms, but they can be attributed to bacteria in the kidney. So they are different from evaluating and management of symptomatic bacteria or UTIs. So first of all, for the diagnosis of asymptomatic bacteria is usually urine culture is the gold standard. Clean catch urine specimen or a catheterized specimen is acceptable. And again, the urine dipstick for leukocyte in leukocyte esterase, evaluation of the leukocyte esterase is important because it will identify pyuria, but it is not specific for asymptomatic bacteria. So in case of asymptomatic bacteria, 2 consecutive urine cultures should be taken. That is mandatory, as it is more common in elderly females who might be pregnant, and the chances of relapses are higher, because once it's treated, the pregnant female, due to the low immunity, can again have get entry of the bacteria without any symptoms. Other than pregnancy, there are also few indications that the um, uh, some patients that having urological procedures in which mucosal bleeding is suspected, such as resection of the prostate, and patients who are in the first 3 months of following renal transplantation. So they are also like more prone to develop asymptomatic bacteriuria. So management is include basically management. As far as management is include, Uh, basically children, patients with diabetes, older patients with spinal cord injuries, and patients with catheterization do not benefit from treatment with antibiotics for asymptomatic bacteriuria. Treatment in these patients does not decrease the incidence of symptomatic urinary tract infections or improve survival. However, it does increase the likelihood of adverse effects from antibiotics and the development of resistance against antibiotics. So, in contrast, when we treat pregnant females with asymptomatic bacteriuria, that has shown to be beneficial. Antimicrobial treatment in pregnancy decreases the risk of pyelonephritis. Otherwise, what happens that pregnant females usually develop pyelonephritis if they left untreated, and there is a higher chances of low birth weight infants and preterm labors. So, in addition, patients undergoing urologic procedures in which mucosal bleeding is expected, such as resections, uh, should be, or the patients who have undergone renal transplant should be treated. So there is evidence that treatment of asymptomatic bacteria in these patients decreases the risk of symptomatic urinary tract infection. Symptomatic abacteriuria, that is called the urethral syndrome, is fairly common in females and 30 to 50 years of usually age group. And according to the uh, different organizations like National Fibromyalgia and Chronic Pain Association, it is urethral syndrome is responsible for the symptoms of lower UTI. Like the person or the female is having lower UTI, usually like in 25% of cases. Why? Because the female urethra is short tube that is responsible for the expulsion of urine stored in the urinary bladder. So urethral syndrome is less frequently reported in males. The risk factors are hormonal imbalances, bacterial infections, medications that alters their pH, unprotected sex, inflammations and infections of the periurethral glands or skinny glands, and immunodeficiency states, previous history of STDs. So all these are the different risk factors that are associated. So what are the basically approaches or the precautions that has to be taken? Avoid products that may irritate urethra, avoid unprotected sex, seek medical help if you're having symptoms, make a habit of emptying your bladder. Uh, you should know about conscious about the hygiene of the of your cleaning of the genitals, avoid wearing tight clothes or so that will help out in these are the precautions that we can take to avoid or against recurrent attacks of painful urethral syndromes. So lifestyle changes are matters, but when we talk about the medications or the treatments, so medications are very important. Lifestyle changes and surgery in case of chronic cases or in case of untreatable cases, like in medication, antibiotics, anesthetics, antispasmodic, antidepressant, alpha blockers are the frequently used. When we talk about the lifestyle changes, healthcare providers advise lifestyle modification to prevent urethral irritation, as I have just discussed about the personal hygiene, maintaining the personal hygienic conditions. Surgical intervention is needed to widen urethral opening or lumen. Urethral constriction is a very common cause of recurrent urethral syndrome in females, secondary to any injury, inflammatory reaction, and scar formation. So these are the uh, uh, basic managements and the treatments and the precautions that has to be taken for the urethral syndromic prevention. So these are the papers I have consulted in making this lecture. Any question I would like to receive, or if you think anything, if you want to ask anything that is you cannot understand throughout the lecture, please ask me. Any question, please? Any question? No question? Everything is understandable? Question, please. No question? Any question? जी लेक्चर मेरा खत्म हो गया, कोई क्वेश्चन है नहीं और टाइम भी हो गया। जी मैं यहाँ से चला